Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, everybody, and welcome to the PT on Ice Daily Show. Christina here. I am one of our lead faculty within our older adult division. Poor you all, you've had me twice this week. And this is one of my last episodes that are going to be here on Instagram before we move the Daily Show over to the app as we get ready for podcast PT on Ice 2.0. Today, what I wanted to talk to you all about was throwing out post-operative protocols. If you've been following me online, you see that I've kind of been on a little bit of a tear about many of our blanket statements, blanket guidelines, and post-operative protocols are no different, right? When we are thinking about our role within rehab, one of the things that really got me thinking is, one, are our rehab protocols evidence-informed, yes or no? Two, who are oftentimes setting out these protocols? It's oftentimes the surgeons. And three, are we respecting everybody's scope of practice, expertise, and experience by doing it this way? So firstly, I do not want to just completely crush on all of our post-operative protocols because they are meant to be very beneficial, right? They are meant to give guidance and guidelines for the best way to get a person back to their previous level of function or beyond after a surgical intervention, right? The idea is that we have a set of guidelines, we have a protocol that we follow that we know are going to give individuals the best chance possible to get back the most amount of function. However, there are two big things, or I guess three big things for me that make me challenge these guidelines. Number one is that when we have blanket guidelines, they are based on or supposed to be given to everyone. And I made the example on Instagram the other day of a person who's getting a rotator cuff repair who is a 40-year-old painter who works in construction, who has to get back to work and using his shoulder 40 plus hours a week, to a person in their 60s who is retired, who has a desk job and isn't really putting much demand. And some of you may say, okay, Christina, like so many of our protocols are for early management and then we kind of build from there. You're absolutely right. But even our early recovery, because it is supposed to apply to everybody, irrespective of tissue health, that means that it's going to be conservative in nature, right? We're going to be a little bit tentative or unsure, or we're going to approach slowly because we don't want post-operative complications, right? We don't want anything that is going to halt progress or create longer rehab than is necessary. And the second part of that is that we are then saying that tissue health doesn't matter. Like the health of the tissue that is undergoing surgery doesn't matter. And we know that to be inherently flawed. When I said that these post-operative protocols don't have any evidence, the two situations and scenarios where it has been tested are showing that we have some wiggle room to grow, right? So an example that I've come on the podcast and talked about before is that we have systematic review level evidence from 2015 that shows that respecting post-operative hip precautions do nothing except for increasing kinesiophobia, and it doesn't actually change our dislocation rate. What does change our dislocation rate is the prosthetic, the approach to the surgery, and the fit of the prosthetic, which has nothing to do with rehab. So that is an example where post-operative protocols haven't really worked. The second area where we've actually seen that liberal restrictions do better is in pelvic surgery. And so if you've taken pelvic level 2, I talk about post-operative management of pelvic surgeries. And in that area, we are actually ahead of other orthopedic conditions where there are now RCTs that look at more restrictive blanket guidelines and more liberal recommendations or frameworks. And so in that, right, in our more strict protocol, we say nothing into the vagina for 6 weeks, and then do not do this, this, and this, gradually return to this, this, and this, and it's much more structured. In our RCT that looked at liberal guidelines, it said nothing in the vagina for 6 weeks because there are still stitches there. But then here are the buoys around you returning to activities around the house and then gradually to exercise that are your signs and symptoms that your body is being pushed just a little bit too hard in this early post-op period, and respect those buoys within yourself. And what that does is it gives, one, some power and control on the person who had surgery, but then also it respects the fact that people are going into surgery with a different level of fitness, a different level of function, a different amount of intentionality of what they plan to do with their body post-operatively, and it gives a little bit of wiggle room. And as you might expect, the liberal restriction group that were given these navigational buoys, that were told how to watch out for, or what to look for that may be considered, that your body is tired, that you've pushed it a little bit too far to say, let's chill out if we can. They did better. So not only did they not have more complications, but their symptom burden post-operatively within incontinence and heaviness were significantly lower than the blanket restriction group. And so in both of these situations, it stands to reason that if we don't have evidence behind our protocols, then we may have a little bit more wiggle room. And then the third part of this is, where does that wiggle room come from, or who gives that wiggle room? Many of our post-operative protocols are set by surgeons, right? Some of them are done in collaboration, at least in part, with the rehab team, but a lot of them aren't. And this is not to be disrespectful to surgeons, but this is to be respectful to my own scope of practice. I respectfully, I have not seen a surgeon who has ever rehabbed a rotator cuff repair from start to finish. I have never met a surgeon who has done a post-operative protocol after their total hip or total knee replacement. Even in their training, I don't think they ever shadow the rehab team to get a full understanding of what they do, despite the fact that often in rehab, we do a day shadowing them. And it would be akin to me saying, oh, I think you actually shouldn't take a posterior approach for that hip replacement. Did you know that it's better to take an anterolateral approach? Have you tried this suture? And this is not me coming down on rehab. This is me advocating for our profession, right? Why would we not be the person who could toggle that framework, that could be able to set the guidelines, set the pace in collaboration with the person that we are spending multiple hours a week with, instead of, following this protocol blindly? And then the challenging part for me, or something that I definitely noticed that has grown within myself, is that when I was a new grad, these were the cases where I got to turn my brain off and stop having responsibility because I would blindly follow this protocol because that was what was expected of me. My cognitive load when I was working with these individuals was very low outside of answering questions and things like that. To be frank, I was being lazy because I thought, well, I didn't have to turn my brain on for this one. I just have to follow this protocol. And that's not the way either. And so now as I'm 10 years into practice, I'm thinking, darn, that's not what I want to do. And I have some individuals who were taking a bigger protective period than 6 weeks. I have others that I am pushing their intensity a little bit sooner, or I'm adding in strength training while we are working on their range of motion so that they don't have as much post-operative deconditioning. That skill set is something that I am very well trained to do. I have medical training. I have a lot of experience working with individuals who have had these different surgeries. And when we are thinking about post-operative complications, when somebody is upset with their rehab, outside of it being a surgical complication, it's not the surgeon that they're mad at, it's me. But I'm not following my own protocol, I'm following somebody else's, and then getting the blame or being held responsible for an outcome that I didn't even I didn't even have any insight into changing or toggling. Now, I know that I'm kind of talking to the converted, right? Oftentimes when I post about this, there was a lot of rehab clinicians that are like, absolutely, like it is time for us to come together. And in this area, it is not that I am trying to bash surgeons. I am trying to advocate for locking shields with medicine. Our healthcare system is burdened. Our healthcare system is burdened, and it's because we have this gatekeeping that oftentimes happens through our physician colleagues, and they are so skilled and they are so trained, right? But we put too much expectation on them, right? Why would I expect them to know all the evidence behind a post-op rotator cuff repair rehab when it's not what they're focusing on? I need them to be focusing on their surgical skills, right? All of the new technology that's coming out in their field that is going to make their outcomes better. And then I need them to rely on me that I am doing the same thing in the rehab space. They are optimizing their surgical technique. They are making sure that the rates of complications are low, that their outcomes are high, that their prognosis is good. And then they need to rely on me that I am staying up to date with our rotator cuff pathologies, our pelvic surgeries, wherever you are going within your clinical practice. I tend to see a lot of individuals post-joint arthroplasty and post-pelvic surgery. Those are my two big buckets, right? Geriatrics and pelvic health. And so I am very up to date on that evidence. If you have taken older adult level 1, you have taken pelvic level 1, you are now up to date with that evidence as well, because I stay up to date with it and then teach you all about it. And so when we are thinking about these protocols, we have to think, are they evidence informed? And oftentimes, honestly, they are not. I have talked to a lot of surgeons who have just said, well, this is a protocol we have always given, and this is the protocol we continue to give. And then when many have not been tested, we know that we tend to err on the side of conservative, right? That is not bad. Individuals are not going to get worse from being a little bit slower for their recovery. But on the flip of where this can be harmful is, one, could we get people better faster? Could we get their function back faster? And if we are conservative in nature, are we unintentionally creating kinesiophobia? Are we unintentionally creating fear of movement because we have put the fear of God into people that if they move faster than this protocol states, they are going to rip something, they are going to cause some sort of issue or complication that's going to make their pain come back. And what we see in some of our literature around hip replacements is that these precautions can cause a lot of fear of movement. And so if we are going to be restricting movement, if we are going to be slowing down rate of progression, and it's going to cause fear, and that fear can be long lasting, right? We see those individuals who won't ever kneel on a knee replacement, even though that replacement was 5, 6, 7 years ago, right? If we're going to create that kinesiophobia, it has to be rooted in the evidence that this is the better way. And if it isn't, then I think giving wiggle room is required. And if we are giving wiggle room, the person that should be given that wiggle room is the rehabilitation providers who have seen these individuals, right? Yes, we are going to respect early wound healing, right? I'm not going to get a person who's 2 days post-op to get rid of all of their restrictions and move willy-nilly and all this type of thing. However, what we see is that individuals naturally are going to protect in that early phase. They naturally want to kind of hug their arm to their body. They have that sensation that they need to protect an early graft. And then as they start to feel better, they start to want to move more. And that is okay. And so what this comes down to, again, is that we need to reconceptualize rehab, right? Frameworks work better than protocols, right? We have some general guidance that, the early 2-3 weeks, we're in more of a protective phase. Here are our things to consider when we're starting to embark on passive active range of motion and strength training around a surgical site. And then here are the sensations, here are the navigational buoys that we need to be respecting in order for our clients to have the best outcomes possible. And honestly, I've been going with this mindset for the last several years, and I have to tell you, my clients have done better, right? Some of my clients I've had to slow down with, some of my clients I've pushed farther, and I've had, clients who've gone to their orthopedic surgeons and they say, show me your range of motion, and they go like this. And the surgeon's like, wow, that's great. You're ahead of schedule. And I give myself a little bit of a pat on the back. They do really well. And we also know how, outside of like that early phase where surgeons are going to have to intervene, how to manage flare-ups in pains or sensations around a surgical graft. So I want to know what you all think. I kind of gave you a loopy argument because there's many facets, and I want to make sure that I was covering all of them around what we think about post-operative protocols. At the very, very least, if we are going to hold strong to some of these guidelines, they need to be tested. They need to be tested. And if they are not, then I think there's definitely way more room for wiggles. And we need to think, they are slower, more conservative protocols. If we do a more speedy, a faster return, are we going to see improvements a little bit quicker? And I think we've tested maybe some protocols compared to nothing, but we haven't really tested different speeds of returning to different activities outside of maybe the ACL literature, but I don't tend to see that active population. And there's just so much that we can do within the space of orthopedics with rehabilitation providers leading the charge. All right, if you are looking to hear me rant all about our post-operative protocols, that is in our older adult level 2 content. There is a prerequisite for that course. That is our older adult level 1, our online course. Both level 1 and level 2, our next cohort starts May 19th. If you are hoping to see us on the road, our next 2 courses, April 5th and 6th, we're in Pinellas Park. That's in Florida. I'm so sorry if I butchered that county name, or that city name. April 12th, 13th, we're in Madison, Wisconsin. That is an almost sold out course. So if you were near the Madison area, you were trying to get into Older Adult Live and you were waiting, I think we only have 1 or 2 spots left for that course. All right. I hope you all have a wonderful rest of your week. If you are not in the app and want to continue watching the Daily Show, I encourage you to get on there. Otherwise, I will talk to you all later.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.